Okay, we'll come back to more, but Asaf, please give us your insights from Boston and the world.
I'll try. Thanks, Chris, and thanks, Nathan. Thanks, Kara, for your presentation to come. I want to make three basic points and share a few slides, but the three basic points are really building off of what Nathan really effectively presented in Minnesota's use case. And by the way, I grew up part of my life in Minnesota, so I have a particular interest in so much of the innovative and important work going on there. The first point really building off of that presentation that I'm going to make is that primary care is really a critical lever and a focal point for actions at the delivery system and payment system level around health equity and community health. That may seem super obvious and kind of an assumption, but I want to just walk through unpacking a little bit of what that then means as we try to get CRISP, and as Maya and others have asked us to do, sort of move from kind of good common slogans that we're all agreeing on to sort of what do we do next Tuesday in the policy and delivery arena. I think the second part that flows, and I'm, by the way, sort of approaching this discussion both as a person interested in policy. I do work with Don at CMMI, but I'm not representing CMMI today. I'm representing sort of a primary care practitioner provider. My clinic is in urban Boston. That is the perspective I'm bringing. And that perspective on the clinical delivery level in partnership with communities is that in order to enact these sort of payment to delivery system transitions and actions, you really need a new team to carry this out. And a new team, not just in roles, but new payment for that new team and new partnerships for the new team to carry out new connections in the community to kind of move that triad of impact that was just spoken about. And then the final point, and it'll be really brief, but I'd love to engage in a conversation because I don't have any answers for this, but it's a question that I think looms large, and I've done some work in international comparative health systems and in low and middle income countries. And it's just the question that really overhangs so much of this is, now that the US has sort of rediscovered the social determinants and structures that impede or promote health that have always been there, we just chose to look at them or not based on various political and social aspects, and the fact that in the US we over-index on healthcare spend and healthcare attention, often at the detriment of social services and other health-creating areas. Now that the healthcare system is sort of redirecting some of that attention, where's the balance and where's the emphasis and where's the risk of over-medicalizing a well-intentioned look to outside of the healthcare system to create health? So those are my 3 points. And if it's okay, I'd love to just share with you a couple of slides. And those slides really come from the committee that I just had the privilege of serving on with Chris. And I'm not going to give you a whole slide presentation, but 2 weeks ago, we released a report on how do you achieve high quality primary care, with the assumption that primary care, and the evidence backs it up, is the only part of the healthcare system that regularly improves both outcomes and equity at the same time. Not always, but it certainly does better than any other part of the healthcare system. And as Don said earlier, this 414-page report can be boiled down to 5 sentences, and those 5 sentences actually start with 1 sentence, which is around payment. And that's that we really believe that we should be paying for teams to care for people and not doctors to provide services. And that's a quietly radical set of recommendations that really boil down to this slide. So Len put it best. I can't really say things better than Len, but our views are not equivalent to the time and work that improve health. I believe that's what you said, Len. And I couldn't, I think we all come to this conversation with that. But where this sort of meets the sort of reality of day-to-day primary care, both pediatrics, family medicine, internal medicine, geriatrics, is that, what we found is perhaps the highest level recommendation with the best evidence is that fee-for-service is fully and totally corrosive to the to the achievement of high-quality, equitable primary care. And we don't need to sort of go into all the details now, but I think if we take that as a starting point, we take it as the next set of recommendations that needs to be quickly phased out, in part by internalizing the RUC's function to be something that CMS does within it so that it revalues its own codes and services as we're moving hopefully rapidly toward the middle and right-sided boxes, which are about creating systems of payment for the kind of care that we wish to deliver and promote that are mostly based on a risk-adjusted capitation system, both socially risk-adjusted and medically risk-adjusted, which have both universal patient assignment and maybe an edge of fee-for-service just to kind of make sure that incentives are balanced out, and that we know that the primary care workforce is not completely ready to move to this payment system. But this will require changing the default payment, revaluing E&M codes, and not just taking the RUC's assumptions along them, and making sure that there are adequate resources for both the transformation that's necessary and all of the health-related social needs and resource connections that cost a lot of money to actually achieve. And that really then ties into something that was said, I think, in the first and second panels, which is that this means that we do not pay for achieving health equity or achieving better community-oriented primary care by assuming that an investment in those appropriate and laudable goals must be then equilibrated with a short-term cost-saving ROI. This is perhaps one of the central faults in our health policy and health payment and health financing logic over the last decade. Now, there are a lot of entities that are already bearing risk, and for them, the key issue is making sure that they're actually flowing funds to the front-facing primary care practices that are integrating community orientation, public health, and primary care services. And for the most part, unfortunately, still being paid on a fee-for-service unit-based mechanism. So key sort of layers of primary care payment policy. I think the second big recommendation is really ensuring that high-quality primary care is available to everyone. And that really starts with this idea of universal empanelment. Empanelment as a denomination function, meaning you know that the community whom you serve and whom you are in partnership to deliver. And that partnership includes real partnership. I'm just presenting a few representative actions from the report that includes community governance, co-design, delivery, patient family advisory council, and partnership with the CBOs that actually create health in a community, and that you denominate who is in the panel of the facility and of the practice that's serving that community, and who is in the panel of payers, and who the payers recognize as being accountable for the care of that community, especially as new resources are being shifted to provide better high quality care with higher equity. That means that you need a new workforce, and a workforce that really delves into the idea of interprofessional care teams that have both core parts of their interprofessional care team and extended health and community parts. And what that really gets into the fact is in my second point, which is that this is a type of community-oriented primary care that really is, it's built on principles of medical homes, but it's even more than that, because here you have a care network, a care ecosystem in which the core clinical team in purple is also extended by key community inputs that delve in and out of patients' lives as their health needs and health holistically and broadly determined really dictate, and that there's an extended healthcare team and community care team that both have ample basis in the evidence for their functioning, but almost all of which, except for those in the unit-by-unit visit-based service, have very fragile lines of support. And if we are to, again, build that connected interstitium of meaningful relationships across communities and not just screen for health-related social needs, but actually refer and make sure that those referrals happen, these other parts of the lattice must be actually well funded. And one data point that sticks in my mind, I'm on the board of Health Leads, which does a lot of work on health related social needs referrals, and their data shows that over 50% of successful health-related social needs referrals are in a community effectively accomplished by less than 2% of the organizations that are in. For instance, many primary care clinics have binders, full of different organizations that they refer to for housing or food resources. So a small number of highly curated, highly effective translational CBOs are doing a disproportionate set of the work, which means we need to fund them. We need to know what they're doing right, and we need to fund that interconnected information conduit to them. Finally, that gets to the IT conduit, which has to be a conduit that's more of an aggregate, comprehensive patient data system that actually flows data, not just across the healthcare system, but starting to flow outside the healthcare system to the key social service systems that we've been talking about today. And that this has to be done with the right measures of use, equitability. We have to measure and denominate who people are in the system to understand where disparities exist. And we, again, this is another discussion perhaps for another day, but we know that current HIT often doesn't count everyone, often miscounts, and sometimes even algorithmically biases against not only historically marginalized, but currently marginalized important groups of people. So this is a huge area. And finally, we need to do all of this with an accountability framework in which we have a scorecard that gets reported to a Secretary's Council within the Health and Human Services and at every state level, in which we have a common, parsimonious, equity-focused, easily or semi-easily collected basis of variables to really understand whether we're making a common set of progress on common metrics and inform the public debates that derive from that. And that gets me to my last comment for the last 30 seconds, which is that as we laudably move to rebalancing, hopefully, spending between health and social services, there are winners and losers. How we will take from some of the historic winners and give to some of the other areas that we need to fund is an important question. And two things come to mind. Number one is the data that in the OECD framework of countries, it's not that the US spends so much more on healthcare that when you combine it with social service spending, it's spending so much on both healthcare and social services. We spend about OECD average on the combination of health and social services. It's just that we spend most of it on healthcare and only about a third of it on social services. In most other countries, that's 2/3 social services, 1/3 health. In that rebalancing, the question I have is, how much do we want to localize control over social service spending within a healthcare system that we can all admit doesn't do a great job of controlling spending and promoting equity and promoting community-based and community health outcomes already? So that's just a hopefully slightly provocative question for us to grapple with as we're saying we're going to move the healthcare system into spending money in all these other areas and taking up the delivery of some of those services or part of the responsibility of some of those services. So with that, Chris, I'll hand it back to you.